I think we are now live.
Yes. So, welcome everyone for this 76th Masterclass on Fertility series. So, last class we had discussed about stimulation protocols for IVF cycles in cases of endometriosis. So today, because the class was really accepted very well and we received a lot of appreciation for that, I think we thought we should have a dedicated class for non-IVF cycle stimulation protocols in cases of endometriosis. And I think this has become more and more common with the fertility specialists or even general gynecologists, where there is increase in the incidence of endometriosis, and either we are treating them with endometriosis or post surgery of endometriosis. So I think it is extremely important for everyone to be aware of the problems, challenges, and also the solutions which we'll have to deal with when we come across such cases. Yeah, over to you, sir. You can start.
Right. So I will just share the screen. Okay. Can you see the screen, Shilpa madam?
Yes.
Okay. So this class is going to discuss stimulation protocol for natural pregnancies. Okay. Now, this has a flow chart again. Do not deviate from this flow chart. Just follow this flow chart. Forget whatever is given in whatever textbook. First of all, I will be very happy to know and tell you that there is no Cochrane review guideline, nothing to stimulate the ideal protocol for natural pregnancy conception in endometriosis. Okay, so nobody can challenge this thing because there is no data available on this. All right. Now, what all should you ensure before you stimulate somebody for a natural pregnancy in endometriosis? First is you should know that the patient should have patent tubes. Okay, that is mandatory thing. Preferable to have the AMH of the patient as more than 0.8. Okay, it is preferable that ovarian endometriomas, if they are present, okay, then ovarian endometrioma are going to be less than 3 centimeter. Even if they are bilateral, it is okay, but ovarian endometrioma should be less than 3 centimeters. Okay. It is important to understand that if there is presence of deep nodules, okay, then these deep nodules should be less than 0.5 centimeters. Okay. It is also important to understand that CA 125 of this patient should be ideally less than 80. Okay. And also it is important to understand that when you do all this janjat, the husband should have absolutely normal semen parameters. Okay. Fine. Now, along with this, okay, I've already mentioned that you should have patent fallopian tubes. This red I'm mentioning because it is for the husband. Okay, I'll again go back to purple color. Okay, again, see what is important to understand in this entire thing is that if your uterus is going to be antiverted, it is a bad thing. Okay, so retroverted or mid flexed uterus is going to be preferable when you want to achieve a natural pregnancy. The reason why I'm stating you all these factors is because these are patients whom you are seeing primarily. Okay, so this is all the conditions which you need to ensure when you have a primary assessment of this patient. Okay, now if in the primary assessment of the patient any of the criteria don't match, okay, any criteria don't match, then the patient will usually require either a laparoscopic surgery, okay, to correct the criteria, or the patient will require IVF, or they will require a combination approach of both. All right, but if you have done a good laparoscopic surgery and radical excision of endometriosis has been achieved, then only remember one line. If radical excision of endometriosis has been achieved, then you should know that you should start stimulation immediately. Okay, start stimulation immediately. Again, because you have completely excised endometriosis, remember tubes will be patent. Remember, AMH preferably more than 0.8. If there is a recurrence, then ovarian endometrioma less than 3 centimeters, nodule should be actually absent. If you have operated, CA 125 will become less than 30. In that situation, husband is going to become husband only. Uterus instead of retroverted may become antiverted. Okay, may become antiverted or stay mid-flexed. Okay, all these situations can happen after a laparoscopic correction, which is why our seniors have always taught us that your first surgery is the best surgery. The reason why it is the best surgery is because it establishes this type of a control. All right. Now, what is important that we should remember as far as stimulation is concerned of these patients? Now, see, remember one thing. This is also the same stimulation which you have to adopt when the patient is wanting to go ahead and do IUI cycles. Okay. So, natural pregnancy means either conceiving spontaneously or conceiving with IUI. All right. So both the things are the same. Fine. So I will just write either conceiving naturally completely or using IUI. Okay. But in both the situations, you are going to do ovulation induction. Here also you will do ovulation induction with IUI. Fine. Fine. So the answers now. Fatafat, we will give you all the answers. Okay. How to start? Okay. In both the situations, you should remember how to start, how to stimulate, how to trigger, okay, and how to give luteal phase support. How to give luteal phase support. And then in 5, I will just label something as special situation. Okay, but special situation I'll come to little later. Okay, so whenever you are trying to stimulate anybody naturally, your target is 1 to 2 follicles. Okay, whenever you are trying to do IUI, your target is 2 to 3 follicles. All right, now all this is assuming that the husband reports are absolutely normal. So the answer is simple. In all of this, you should give pre-treatment antagonist. Okay, do not deviate from this protocol at all. Pre-treatment antagonist is given as 0.25 of cetrotide or ganirelix. Okay, and this is to be administered for 1 to 2 days prior to starting. Why should you do this? Because asynchrony of follicles is common in endometriosis. All right, how to stimulate? The answer of choice, do not use your head again, is to give always a combination of letrozole plus HPHMG. Letrozole plus HPHMG is always to be given in a combination of 2.5 plus 150, and it is to be given for 7 days. The reason why it is to be given for 7 days is because with this 7 days of stimulation, usually you will achieve follicular size of 18 to 20 millimeters. If you give it for less, then due to the toxicity of peripheral endometriosis which is present, some of these follicles may undergo apoptosis and atresia. Okay, and it will result into having empty follicles. Okay, so take that gamble. Use HMG plus letrozole for 7 days. How to trigger? The answer for this is a one-line answer. I'll always give 10,000 HCG trigger if the patient is trying naturally or the patient is for IUI. Both the situations 10,000 trigger. There is no role of giving GnRH agonist in this case. Okay, GnRH agonist when you are trying naturally. No role. Okay, no role. It will affect the endometrium. How to give luteal phase support? The answer to that question is again very straightforward. Luteal phase support is given in the form of progesterone gel, and this progesterone gel is an 8% gel which is given once in the morning, once in the evening. That is more than enough for these patients to be given for approximately 13 to 14 days. All right. Now, I told you that I will come to certain special situations. Why did I tell you that? Because these special situations, okay, are such that you will think that there is a luteinized unruptured follicle. This is common in endometriosis. If this occurs for 2 times consecutively, then the treatment of choice is to do a diagnostic plus therapeutic laparoscopy, and in that you are compulsorily supposed to do peritonectomy. Okay, compulsorily supposed to do peritonectomy because it is very, 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 very common. Okay. One more thing which I want to mention in a special situation is we have done it many, many times in in Bangalore, and we have told that after the surgery is complete, I mean, after post laparoscopic surgery, one can consider to give injection placentrex 21 days. It is off label use, it is an IM injection which you can give for 21 days. It settles the edema and it helps these patients attempt a natural pregnancy. This entire protocol you should try for your patient for approximately 4 to 6 cycles. In 4 to 6 cycles in our series, the cumulative pregnancy rates have been 30% over the last 5 years, and we have never deviated from this protocol. There is absolutely no role of deviating from this protocol because we have standardized this as a protocol. And in our series, this has given us fantastic outcomes. So I just thought I should share it with you. Okay. With this, I conclude, and Shilpa madam can probably ask questions.
Yeah. So what happened? You told CA 125 less than 80 in primary patients. So I think, isn't it a little high? I mean, don't we consider 35 as the cutoff?
Yeah.
Why keep it
35, yeah. 35 to be taken as a cutoff, madam, but we have just decided out of our data that CA 125 should be less than 80, because more than that, no, it usually indicates gross peritoneal inflammation due to endometriosis. And usually when the value is like that, no matter what we try to conceive naturally, the conception rates are very less, madam.
Okay, tell me this, like you don't see any disease actually, like, I mean, no uterus is antiverted, no adenomyosis, ovaries are free, and no ovarian endometriomas or anything. But if the CM125 is hovering between 50 and 60, would you still go ahead and stimulate them without actually thinking about peritoneal endometriosis?
Yeah.
Okay.
Yeah, I would keep in mind peritoneal endometriosis. I would stimulate for 1 to 2, maybe 3 cycles with letrozole plus menotas. If it doesn't really work, madam, I will post them for a diagnostic scopy. You will find patches of peritoneum which is involved with endometriosis. And when you do that, and when you do a wide local excision of that, okay, usually again after that in 2 to 3 cycles, the patient will conceive.
Okay, so this protocol that you mentioned, so is it for all patients, irrespective of whether they want to go ahead with laparoscopy, or do you offer laparoscopy first and then do all this if they're not willing for laparoscopy, if there are cysts? Or
no, I mentioned the criteria, madam.
Okay.
If the ovarian cyst is, let's say, 8 centimeters, then I will not put them on natural intercourse or IUI protocols only. The answer is to operate.
No. My question was, see, all these criteria are met with the couple, okay, whatever you have mentioned, okay. But since you are a referral unit, so they would have gone to 1 or 2 other people who would have told them to do a laparoscopy of 3 centimeter lateral ovarian cysts and all that. So if the patient is in a dilemma, okay, you would still go ahead primarily and do stimulation for 3 cycles and then go ahead with laparoscopy?
Yeah, otherwise, if as long as she falls in this criteria, she can be stimulated without laparoscopy. Simple answer.
Okay. Yeah. So in this, you haven't taken age as a criteria. Okay. You have only taken the AMH as the criteria. So you think age as an individual factor, it's not confounding thing in this? I mean, you don't give it much importance?
No, madam.
Okay.
No, not in our data. There is only one thing which I have not mentioned, which we look into, okay, and that is if the size of the uterus is less than 8 centimeters. Okay, the reason why I did not mention it is because quite a lot of times when you have associated focal adenomyosis, okay, and the uterine size is more than that, then we will not include them into stimulation protocols. We will ask them to get operated for focal adenomyomectomy, wait for 2 months, and then stimulate them naturally.
Okay. Yeah. So what happens in cases where there is all hyperestrogenic factors are there, like there is PCO, there is endometrioma, which are less than 3 centimeters, and multiple small fibroids. So these are the situations that we are seeing more and more these days. So in these situations also, like you just go ahead and stimulate them, like primarily?
Yeah, primary stimulation as long as they match the criteria.
Yeah. And have you tried using CC? Because in endometriosis cases, because these are all endometriosis is estrogenic dependent inflammatory condition. So giving anti-estrogen like clomiphene citrate, do you think it would help in terms of reducing the estrogen levels?
No.
Okay. And letrozole, you do extended letrozole protocol in these cases just for
7 days.
7 days, not more than 7 days, right? Till the
No.
follicle reaches 16 millimeter, 18 millimeter. Do you continue or you just give it, your cutoff is 7 days?
7 days.
Yeah. And do you add steroids in the stimulation to reduce the
No.
inflammation for immunomodulation? No?
No.
Okay. So trigger, you think we should trigger them a little early just in case, or should we trigger them a
No.
little late?
18 to 20.
Okay. And have you noticed a lot of premature LH surges in these cases in your data of so many patients that you have treated?
Not if they fit in the criteria. Premature LH surge will occur especially when peritoneal endometriosis when CA125 is, let's say, 145.
Yeah.
Okay, then
Yeah.
you will have premature LH surge and LUFS both, which is why I mentioned that as a special situation.
Yeah. So, what happens in case if both the ovaries are adherent? Okay, I mean both the ovaries are adherent, but you don't see any cysts in the ovaries. Okay, and there is slight adenomyomas, as in like less than 8 centimeters, of course. So, do you give it importance because you are suspecting adhesions inside where it could lead to like LUF and I
See, as
think
long as the tubes are patent in the primary evaluation. Okay, you said that both the ovaries are adherent, right? In that situation, the probability that there is also the presence of a nodule is very high. Okay, when both the ovaries are adherent, more than 90% chance that a nodule is present. In that situation, most of these girls will end up with a laparoscopy, madam.
Okay. So tell me in these cases of endometriosis, especially in young girls, like 23, 24-year-olds who come with like severe disease where there is a nodule of less than 0.5 centimeters and all. So do you feel that I mean, the age factor, like the earlier they get the endometriosis, the severe it would be? Is there any correlation like that?
No, nothing like that.
Okay, and take it for example, if they have already been operated before, say like 3 years back or 4 years back, and then they come to you and they match all these primary criteria, okay, with the cyst in both the ovaries, you still go ahead and primarily stimulate them, or you think because first surgery has been a failure and there is a recurrence, you would go and clear it up and then do the stimulation?
As long as they match in the criteria, we would want to stimulate, madam.
Okay. So what is that one factor which tells you like, no, I don't want to stimulate this patient. You just want to go ahead with the surgery. I know because you're, I think a
Any
surgeon.
nodule more than 0.5 centimeters.
So that would be, so you would suggest everyone here who are attending the class to do a rectal examination, check whether there are any nodules when they see a case of endometriosis, when there is even a smallest of the chocolate cyst. I think everybody should learn to do a PR just to check for the
Yeah, because I mean, see, I would be happy, madam, if you can describe your experiences of doing per rectal examination ever since we have started coming to your setup. And I think you would have probably examined more than 100 endometriosis patients per rectally by now, because more than that we have already operated. So maybe you would have examined, let's say, 200 patients, right? How much difference it has made in your clinical judgment of endometriosis? Don't you agree to that, madam?
Yeah. I think it's a life-changing year for me, the last year, because I never used to do a PR examination till you had asked, first time you remember, we missed a bowel nodule. So
Yeah.
I think after that only, for every case of endometriosis, even if there is no endometriotic cyst, or if there is nothing, even if there is small adhesions in one of the ovaries also, now we do a PR, and surprisingly we see about 10% of them having nodules. I mean, it could be small ones or it could be big ones. Of course, big ones are less than 3%, but invariably we kind of see these nodules, especially when the ovaries are adherent, as you said, and when there are bilateral ovarian cysts, and when the patient has severe pain, when they come with severe pain and there is no correlation between the ultrasound findings or their MRI findings. In that time, when we do the PR, we find the nodule, which has been missed in, I think, majority of the tests that they have done. So I think a good message that we should give everyone, that they should start doing a PR examination now for every patient of endometriosis that they see even before they stimulate. Because once they start stimulation, I think there is no end, because the patient will not be willing, because there is no other factor there. Everything seems to be okay except for one small 2 centimeter cyst. So this is an important point that we would want to tell everybody. So anything else you want to cover? I mean, what are the surprises have you seen in your practice? I mean, with so many cases of endometriosis, I know you don't treat as many minimal and mild, moderate disease. Mostly it will be severe disease. But if at all, if you have seen minimal and mild disease.
The more severe the disease, the more fertility enhancing that laparoscopic surgery becomes.
Yeah.
Okay. If it is great for bowel endometriosis, and if you go and do a bowel resection, brilliant outcomes for natural conception as long as fallopian tubes are fine. Believe me on this. Because every year we would deliver more than 100 like this in my hospital, because we are treating so many, and so many will come back to become naturally pregnant with us. Okay. Even today we had 3 pregnancies, all 3 post bowel resections, all 3 with just natural intercourse. Okay. All 3. When I told you that you want to do something, the reason why I told you is because we had all 3 back to back pregnancies today. So it just struck in my head that okay, this is this is an important topic, probably we can cover it, which is why I told you that.
Yes, yes.
But
I
the
think this is a very
outcome,
good point. Yeah,
yeah,
sorry.
the outcome, sorry, the outcome for fertility will improve drastically if it is a bad case. If it is a frozen pelvis which has been abandoned, and if you have saved the fallopian tubes, her outcome is phenomenal. Okay. The outcomes are very much, there is a very much minor improvement in the outcomes if the disease is also very much minor.
Yeah,
Okay.
yeah.
That is something which should be a take home point, I think.
Actually, the tubes look quite bad when we actually do the
Yeah.
laparoscopy, but it's
Yeah.
not bad. It is not actually that bad once you start doing the adhesiolysis and once you try to bring the anatomy back to normal. What do you say on this?
So, definitely tubes would be bad. And the reason for the tubes being bad is simply because of the hypervascularity which happens in the broad ligament, in the parametrial region. That is one. Second, the anatomy of the tubes get altered. Correct. When the tubal anatomy is altered, no, madam, you must understand that in the mesosalpinx, the veins which go to form the IP ligament, okay, they don't have so many valves. So if due to pressure compression, due to altered anatomy, if the veins are getting kinked there, okay, it will cause congestion in the fallopian tubes. It is very normal, which is why we think that the fallopian tubes are edematous. Okay. The minute you release those adhesions off, the vein, the venous anatomy, the pampiniform plexus of the ovary, it settles down. And in the next 1 to 2 months, the anatomy for that fallopian tubes improves drastically. Okay. Yeah. And that gives rise to so many natural pregnancies.
Yes, yes, yes. Yeah. So I think that's about it. I think it was a very good one. Thank you so much for your time.